Can you see the screen? Can you see this PowerPoint?
Yes, sir.
Okay, fine. So first we'll discuss about the indications to do ABG, then how to perform an ABG, and about the basic interpretation of an ABG. Okay. So tell me if I'm too fast. You can always stop and ask me to repeat what I have told. So in the feedbacks, one of the main things I noticed was that the speed was I was doing too fast. So if you don't understand anything at any point, you can always stop and ask. Don't worry. So the purpose of doing this meetings is to for your benefit, not for my benefit. ඔයගොල්ලෝ දැන් සල්ලි කාලෙන් දෙකම නාස්ති කරන්නේ වෙනද කාලෙ විතර දැන් සල්ලිත් නාස්ති කරන්න එපා ඉන්ටර්නෙට් වලට. ඒක නිසා, and the other thing is some have asked to do only 1 hour instead of doing 2 hours, saying that it's too much. Like sometimes it will be difficult to finish the thing in 1 hour because I have to explain a lot. Then what we can do is we can stop in 1 hour and then to do the next session on the other day. So we just see after 1 hour how things are going, and then if you feel that it's too much, we can stop and do it in the next day. So that's why I asked to give the feedback, so I know what your wishes. Otherwise I'll do as I wish. Okay, to start with, how to perform, the topic is how to perform ABG and basic interpretation. So to start with, regarding doing an ABG, I'll ask some questions. Can somebody tell me how would you do an Asangi? Can you tell me? Like, say that you're in the medicine ward and your HO has asked to do an ABG on a patient, on a pneumonia patient who is dyspneic. So how would you do the ABG? How would you perform the ABG?
So first gather the equipment.
Okay.
ABG syringe with heparinization.
Hold on. What do you mean by an ABG syringe? So when you do a procedure, what's the first thing that you should do? Maybe you're doing ABG, a cannula, intercostal drain, a lumbar puncture, or putting the patient into sleep during anesthesia. So if you're doing an intervention to a patient, what's the first thing that you should do as a good doctor?
Explain the procedure.
Okay, so you should explain to the patient what you're going to do and take the consent. Usually, if the patient is awake, we take the verbal consent, and if the patient is under sleep or the patient is intubated, we can sometimes we can ask the relatives, or we can do it in the best interests of the patient. Okay, so taking consent is a good thing that a doctor should do. Like, it's not compulsory, it's of good practice. Always we can weigh the risks and benefits, and if the procedure is beneficial for the patient, we can do it. Okay, first thing is we can do, if the patient is awake, take verbal consent. So what would you tell the patient? patient කෙනෙක් ඉන්න වාට්ටුවේ කොහොමද කියන්නේ මේ බ්ලඩ් ගෑස් එක ගන්න කලින් මොකද්ද කියන්නේ? ලේකක් ගන්නවා කියලාද? සිංහලෙන් ඉංග්‍රීසියෙන් කියන, I don't know whether everybody is English. Sinhala is here. What would you tell the patient? Go.
First, I select the site.
No. What would you tell to the patient? Yes, you have. So suppose, assume that you are going to do the blood gas from the radial artery. What would you tell the patient? දැන් ඉතින් එහෙනම් ABG එක ගන්න එකයි මේ විනස් සාම්පල් එකක් ගන්න එක වෙනසක් තියෙන්නේ පයි. දෙකම එක ලේකක් ගන්න ඕන අරක දැන් විනස් සාම්පල් එකක් ගන්නවා වගේ නෙවෙයි ABG එක ගන්න ඕනේ. දැන් රේඩියල් ආර්ටරි එකෙන් අර චූටි සිරින්ජයෙන් උනත් ගහනකොට රිදෙනවා මේ ආර්ටිල් පංචයක් කරනකොට. සෝ කියනවා මේ ලේකක් ගන්න යනවා මේ වගේ නහරකින් සාමාන්‍ය ලේක් ගන්නවට වැඩිය පොඩ්ඩක් රිදෙන්න පුළුවන්. ඒ නිසා පොඩ්ඩක් ඉවසන් ඉන්න කියලා කියනවා. Sometimes we can give a bit of locally if we want, but සාමාන්‍ය කියන අරම දැන් ABG එක ගන්නොත් තව 20 වෙනවා මේ නිකන් අර ආර්ටිල් පංචයක් ගන්නවා කියන අර පොඩ්ඩක් අනින්න එපා ඇතුළට. අනිත් එක සමහරලාට එකපාරින් ගහන්නත් බෑනේ ඔක අහුවෙන්නේ නැති වුණොත් එහෙම. ඒක නිසා එහෙම තමයි කියන්න ඕනේ මේ චුට්ට හරි දෙන්න පුළුවන් සාමාන්‍ය මේ ලේකක් ගන්නට වැඩි පොඩ්ඩක් ඉවසන් ඉන්නේ කියලා. හරි හරි then what to do? අනිත් එක ඒක වෙනකොට මේ දාන්නෙත් නැහැ මේ ටර්නිකේ දාන්නෙත් නැහැ. එතකොට patient බලයි මේ මොකක්ද කියලා කරන්නේ. So that's for your knowledge that I told that bit. Okay. Then what would you do?
After explaining the procedure, I will gather the equipment, including 1 milliliter syringe and heparinase, and I collect cotton wool to clean the site, ice pack, and stopper to keep it fresh. Then that was.
Okay, fine. That's good. Okay, so you missed one part. So first thing is before doing an ABG, even before taking the consent, we have to think about the indications as well as contraindications. So if there are contraindications to perform the ABG, we should not do it. Basically, when somebody asks, if the HO asks to do ABG, so in this patient, it was a patient who has pneumonia. So you look for the indication, then subsequently you check whether there are contraindications. So one thing is patient can refuse. Then there can be local sepsis at the site. Then there can be abnormalities in coagulation. Say if there's a patient with an INR of 3 or 4, it might be a bit tricky to do an ABG unless it's really necessary. Then if there is a wound or fracture in the site, then those are the contraindications to do ABG. Or then other thing is if you can't have you heard something called Allen tests? Don't worry about it. There's something called Allen test. Do you know about it? Where it's a test that you do to check the peripheral circulation of the hand. You make a fist, then at one time you apply pressure on the radial artery and obstruct it, and ask the patient to open the fist. Then if there is reddening of the hand, then you think that there's good collateral circulation from the ulnar side, and you do it on the other way as well. You obstruct the ulna and ask the patient to make a fist and open the hand, and if the radial is intact, there will be redness of the hand. So you can read about the Allen test in a book. If the Allen's test is positive, then you should be a bit cautious about doing an ABG. If it's positive for the radial side, then you should avoid doing the ABG on that side. Okay. So what are the sides that you can do ABGs? One thing is radial. What's the other common side that we use? We can use the femoral as well. Okay. So sometimes in ICU patients, the radial will not be palpable, maybe because of hypertension or maybe because of peripheral vascular disease. In those sort of situations, use the femoral instead of the radial. Okay, and what are the contraindications? What are the complications of doing ABG? Anybody? Can somebody tell what are the complications of doing an ABG? Chaturika?
Bleeding.
Sorry?
Bleeding.
Okay, bleeding. If it's if the patient is has a coagulation abnormality, he can get bleeding. What else?
Hematoma formation.
Okay, still if the patient is coagulopathic, you can get hematoma formation. Bleeding, hematoma formation. What else?
Thrombosis.
Okay, thrombosis. What
Oh, damn.
else? Sorry? කියන්න බෑ නේද?
Artisan nerve damage.
Okay, you can damage the surrounding structures, but it's unlikely when you do an ABG. So it might be a very rare complication. Like if you do for the femoral, then there's a chance of damaging the femoral nerve, but it's very rare. Okay, what else?
Vasospasms.
Okay, vasospasm. What else?
Air embolism.
Infection risk.
Okay, infection risk and air embolism. Those are rare ones. And you can get dissection of the artery as well, but it's rare. So basically bleeding, thrombosis, bleeding, hematoma formation, spasm, then rare ones are air embolism, damage to the surrounding structures, and maybe dissection and thrombosis. Okay, so those are basically the complications. Did you understand about the Allen's test? Sometimes Haporachis sir asks about it. He likes that test. Did you understand it? So there's a thing called modified Allen test and Allen test. There are two things, but Allen test තේරුණාද? Dylan, did you understand what's Allen's test is?
Yes, sir.
Okay. Then the next thing is how would you do the ABG? So when you do, can you see the screen?
Yes, sir.
Okay. Don't look at the screen, just concentrate on what I'm telling. So when you do the ABG, you must specifically tell that you take an insulin syringe. The person who answered the question told that I'll take a ABG syringe. You must specifically tell what syringe that you would use. So basically, before doing the ABG, you make sure that there are no contraindications. Then take the consent of the patient, and then you must call the board and call the ICU and check whether the ABG is working. That's sample so make sure that those are practical aspects. So ABG analysis, you must make sure that the analysis is working. Sometimes they run calibrations. Calibrate you won't be able to do an ABG. You have to wait for like 15 to 20 minutes sometimes. So make sure you call the ICU and make sure that the analysis is functioning. Then take the necessary equipment. So you must take a insulin syringe, which is 1 ml. With what sort of needle would you use? Needle part ABG. Suppose that you are doing a radial one. මොනපාට මේ සිරින්ජ් එකක්ද ගන්න?
Blue color.
මේ කට්ට
Blue color. Blue color.
මන්න බ්ලූ එකක් ගන්න. බ්ලූ එකෙන් ගන්න පුළුවන්. බ්ලූ එකෙන් ගහුවොත් දෙනවනේ. අර මේ ටැබ්ලියෙන් කරන්න පුළුවන්. You can use the orange needle. අර චීනිම චූටිම එක. රේඩියල් එක ගහනකොට මේ අනගෙන බලන්න නිල් එකකින් තරු විසිරේ. මේ බෙස්ට් එක ගොඩක් කට්ටිය ගන්න බ්ලැක් එකනොත් ගහලා මන්ද කරලා තියෙනවා. අපේ නිල් එකනොත් ගොඩක් කට්ටිය ගන්න නිල් එකනොත් බ්ලැක් එකනොත්. Best thing is to do with a pink one. ඒ රිදෙන්නේ නැහනේ. if you do a femoral one, then of course you can use the blue one because the femoral artery is situated a bit deeply. So otherwise, if you do a radial one, you can use the orange one, the smallest needle, unless it's a big chap like who is 150 kilos, which is like which is unusual in our setup. So best thing is to take a 1 ml syringe with a orange needle, the smallest one. Then you have to hyperonize the syringe as well as the needle both. Then you have to tell the patient, and other equipment you need is you need the cotton swab and something to clean, or otherwise you can use this alcohol wipes which are ready made. Okay, then it must be done as sterile procedure. You need sterile gloves. That's the ideal, but you can use normal gloves. Ideally you have to use sterile gloves. Then you have to position the patient correctly, position the hand. Suppose that you're doing the radial one, then you must position the hand in the correct way. So this is how you position. You can put a gauze roll or something under the patient's wrist to hyperextend the wrist, so that you can feel the pulse very well. Then what you do is you palpate wear the gloves and wash the hands, wear the sterile gloves and clean the area with 70% alcohol or betadine. Then what you do is, if you want, you can apply local or without. You can do it without doing local. Then you feel for the radial artery and feel the point where you can feel the maximal pulsation. Then what you do is you advance the needle at a 45-degree angle. Last time when I did the class, your colleagues told that you should advance the needle at a 90-degree angle to skin. Then artery, when you advance the needle at a 90-degree angle, you will be advancing the needle to the perpendicular to the artery. The flow එක තියෙන්නේ proximally the distal මේ පැත්තටනේ තියෙන්නේ. So when you direct it at a 90-degree angle, the flow will be perpendicular to the needle. But if you advance the needle at a 45-degree angle or at an inclined angle, then the flow will be towards the needle, not at a 90-degree angle. So it will be easier to take the sample. This is important not in like healthy patients. Even if you do a 90-degree angle, you will be able to get the sample. But if you say if you can't feel the pulse, then if you do it at a 45-degree angle, it will be easier to get the sample. Okay. So once you advance the needle at the point where you get the maximal pulsation, when you enter the artery, there will be a flashback. Then you can take the sample. Okay. So after taking the sample, you should apply tight dressing and hold it for some time until hemostasis is achieved. Okay. So then you thank the patient and safely dispose the needle. So after taking the sample, what you do is you put it in a ice container and take into the ICU. So while processing the sample, you should make sure that there are no air bubbles. Okay. I'll send the presentation. Don't worry. I didn't go through I didn't actually read the presentation. Like, okay. So don't worry. I'll be sending this presentation and the answer to the previous questions as well. Any questions about doing the ABG? So if you do a femoral one, since you are advancing the needle a bit deep, you can always give local. When you do the radial one, it's not always necessary to give local anesthesia. But if you do femoral in an awake patient, it might be better to give some local because you have to advance it a bit deep. Okay. Any questions about it? Okay, fine. Anything you want to ask about those things? About the indications, contraindications, about the Allen's test and how to do it, how to do the ABG.
So can you give us an account about modified Allen's test?
Modified Allen test, actually I can't remember it. I know only the Allen's test. Why don't bother about the Allen's test much, because it's like a historical one. Even when we do a ABG, like even when we do a arterial catheter, we don't do the Allen's test now. It's a bit of a historical thing, but sometimes even for sometimes for the OSCE, you might get a question on Allen's test, because Herpert's likes it. If you want, මට ඇත්තට මතකද modified එක න. උරු කියන්න ඕනේ නෑනේ. Why did you want to know about the modified one? Was there a question?
No, sir, there wasn't the question, but I just asked.
For entry, I'll tell you next day. I can't actually remember the modified one. We don't use it, so I don't know it actually. I had to read it. I know that there's something called modified, but I can't remember it. Anything else? Sir, do we need to remove all the heparin in syringe, or need to spare a little bit of heparin in syringe? When you don't have to leave any heparin in the syringe. Completely flush it off. The idea is to heparinize syringe, not to leave heparin in the syringe. If you leave heparin in the syringe, it can interfere with the analysis. That's a mistake that most of the people do. Sometimes they leave a bit of heparin in the syringe at the hub, or maybe at the bottom of the syringe. Anything you want to ask? Any other things? मैं 10 පාරක් විතර අහන්න යන ස්පීඩ් එක වැඩි කියපු නිසා කියන්නේ ඕන ප්‍රශ්නයක් අහන්න. තේරෙන්න තියෙනවා ඕන කෙනෙක් ඕනයක් අහන්න. නැත්නම් we'll go to the next one. Okay. So next part is about the acid-base balance. Before I'll just touch on acid-base balance before we move on to ABG interpretation. So when we talk about acid-base balance, what's the importance of maintaining a fine acid-base balance in the body, like maintaining normal pH within the body? What's the importance of it? Ashika, why do you want to maintain an optimal pH within the body, within the extracellular fluid as well as intracellular? Ashika. Okay, Bhagya.
Because with the enzymes of the body, that the enzymes are made of proteins, and it can be change the functions.
Okay, one thing is for the optimal function of the enzymes, like to make sure that the metabolic processes within the body are optimally functioning, you need an optimal pH. That's 7.35 to 7.45, isn't it? So the pH is the hydrogen ion concentration within the body, and because the hydrogen ion concentration is very small in the body, it's like 10 to the power, how much do you know? So when we deal about electrolytes, say for example sodium and potassium, the units are milliequivalents per liter, isn't it? So, but when we talk about the hydrogen ion concentration, it's the hydrogen ion concentration is something which is 10 to the power 9, like something like that, 10 to the power 12 or something. minus 12. So it's a very minute. The amount of hydrogen ion in the body is very extremely small. So because we want to deal in a for our convenience, we use this log scale to denote the hydrogen ion concentration. So we express the hydrogen ion concentration as the 10 to the as the 10 to the power log, like hydrogen ion concentration is equal to log 10 to the power something. Okay, so what, as I told, the normal hydrogen ion concentration, which is denoted by the log scale as pH, is 7.35 to 7.45. So how do we, as if it's important to maintain the hydrogen ion concentration within a certain range, what are the mechanisms in the body to make sure that the hydrogen ion concentration is within the normal range? There should be certain mechanisms, isn't it? Because with the metabolic processes, there will be hydrogen ion added, and because of respiration as a byproduct, there will be carbon dioxide accumulated. And after digestion of food, there will be various acids accumulated, added into the blood. So in order to get rid of this excessive hydrogen ions, the body should be able to have a control mechanism, isn't it? So what are the control mechanisms in the body to maintain the pH or hydrogen ion concentration within the normal range? Chaturika.
There is buffering.
Sorry?
Buffering system in body.
Which system है हुन्ने? මොකද කිව්වා?
Buffering system.
Okay, what are the buffering systems? So when you answer that question, you can tell that there are mechanisms to like control it. There are short-term control mechanisms and long-term control mechanisms, isn't it? So the short-term control mechanisms are the buffers in the body. Like there are several buffers. What are the buffers in the body which are useful for the short-term control of acid-base balance?
Bicarbonate buffer system.
Okay, you have the bicarbonate. What else?
Ammonia.
Ammonium is actually in the renal, isn't it? In the kidneys. It comes into
Phosphate. Phosphate buffer system.
Okay, phosphate. So you have, main thing is the bicarbonate buffer system. You have the phosphate, then you have the hemoglobin, then the plasma proteins. Then, as you said, in the kidneys you get the ammonia buffer system, but it's useful for the long-term benefit, isn't it? Then, so one thing is the acid-base status is maintained by buffers. What are the other things? The other thing is by the respiratory system, isn't it? By washing off the excessive carbon dioxide, which in turn by regulating the H+ concentration and as well as the bicarb concentration, the body, the respiratory system maintains the pH at a normal range. Okay, that's intermediate. Then at long term, how does the body maintain the acid-base status? By the kidneys, isn't it? So the kidney can get rid of the excessive hydrogen ion concentration by various mechanisms. Or one thing is it can produce ammonia and combine the hydrogen with ammonia and excrete as ammonium ion. Otherwise, the hydrogen ion will be secreted and it will combine with phosphate and will be excreted through the urine. Then other mechanism is the body can, the kidneys, in addition to secreting hydrogen ions, it can also absorb bicarbonate, isn't it? Can you remember in renal physiology? in the proximal convoluted tubule, almost all the bicarbonate, 99% of the bicarbonate which is filtered by the glomerulus is absorbed in the proximal convoluted tubule. So by that, the kidney maintains the acid-base status. Like if you lose all the bicarbonate ions which are secreted, then there will be excess of hydrogen ions, then there will be acidosis, isn't it? To prevent that, the kidneys absorb bicarbonate ions. So mainly the kidney regulates acid-base status. One thing is by absorbing bicarb, other thing is by secreting hydrogen ions and combining it with various buffers in the urine, such as phosphate and ammonia. Okay. So what's the use? Say there's a patient with respiratory metabolic acidosis. So say there's a patient with diabetic ketoacidosis, and because of the ketoacids added into the plasma, there will be an acidosis, isn't it? So how will the body try to normalize or try to bring the pH back normal in that case? Can somebody tell me? Say there's a patient admitted to the ETU with diabetic ketoacidosis, and with regard to acid-base status, the body, because of the ketones added to the blood, the body will always try to combat the H plus and try to bring the H plus into back to normal. So how would the body do that?
Hyperventilation by Kussmaul.
Okay, one thing is so because of the big ketone load, the initial buffering will not be adequate, isn't it? So as I told, the first thing will be the buffers in the body, which will in the short term, which will act to counteract the H plus. So the bicarb will try to combine with the hydrogen ions produced, but it won't be adequate. So then the respiration comes up. As Varuna told, the respiratory system will be stimulated, and it will try to wash out the CO2. So because of that, the patient will be hyperventilating, and you will get this typical Kussmaul breathing pattern. So what else will happen? And in the long, and after about 48 to 72 hours, if we don't do anything, the body will try to excrete the hydrogen ions through the renal mechanisms as well. So the problem with the renal mechanism is it will take some time to bring the pH back to normal. Okay. So suppose there's a patient with high respiratory acidosis. Suppose there's a patient with COPD who suppose there's a patient with respiratory acidosis. Say there's a patient with head injury, and the patient's respiratory rate is around 8 to 10, and he is hypoventilating. Because of that, there's carbon dioxide accumulation, and there's a respiratory acidosis. Say the pH is 7.25 and the carbon dioxide is around 100 millimeters mercury. Then how would the body compensate for that? How would the body try to normalize the pH or bring the pH back to normal? Kandambi. කවුරු කියන්නකෝ respiratory acidosis එකක් how would the body try to compensate? So if the problem is in the respiratory system won't be able to compensate, isn't it? Initially, the buffers in the body will try to compensate, but that's not adequate. So what will happen? අනේ කියන්නකෝ කවුරු හරි ජීවන්ත ජීවන්ත වල පොරක් වෙනවා head injury එක with has a head injury and has a respiratory rate of 8 to 10 and he's hyperventilating. So CO2 is 100 and has a pH of 7.3, 7.25. The acidosis is of pure respiratory. So how will the body compensate? Then keyword buffering systems, ඇගේ තියෙනවා වැඩ කරනවා hemoglobin bicarb phosphate ඒව ටික ඊට පස්සේ එනවා respiratory system එක ඊට පස්සේ එනවා kidney එක දැන් මේ හදයගේ මේ the respiratory system is not working so the body will initially compensate with the existing buffers then what will happen?
Renal compensation.
Try to compensate with renal compensation.
But renal is taken, yeah, the renal will try to compensate, but it will take around 48 to 72 hours, no? So the kidneys will take some time. So what should be done for that? You should intubate and ventilate the patient, isn't it? Then if the short-term buffers are not adequate and if the respiratory system is involved and if the kidneys take time to resolve the acidosis, then what we should do is we should support the respiratory system. That's one of the indications to ventilate a head injury patient. If the CO2 is climbing, because the kidney will be taking some time to act, then you should pass a tube and ventilate the patient and get rid of the CO2. Okay, and ventilating per se will improve the acidosis. And we'll talk about it when we talk about the examples. So by if a patient encounters an acid load, the body will try to bring the pH back to normal with the compensatory mechanisms. But the thing that you should bear in mind is the pH will not bring to near normal. It will come back to near normal. That 7.35 තියෙන එක 7.35 වෙන්න ගොඩක්ලාට ඒ කිට්ටුවට ගේන්නේ. So the compensatory mechanisms will bring the pH back only to near normal. It will not completely normalize the pH. Okay, unless it's a chronic process or a mixed disorder. හරිනේ? Acidosis එකත් ආවත් එහෙම alkalosis එකත් ආවත් එහෙමයි. If a patient has a respiratory or metabolic alkalosis or whatever, with these compensatory mechanisms, the body will try to bring the pH back near normal, but it will not normalize the pH. So when we talk about acid-base balance, there are mainly 4 disorders that we should know about. One thing is if there's a problem in the respiratory system. So because of that, you will get respiratory acidosis or respiratory alkalosis. You get respiratory acidosis because of excessive accumulation of carbon dioxide. And on the other hand, you get respiratory alkalosis because carbon dioxide will be washed off. Acidosis, you get acidosis because of carbon dioxide. By dissolving it, water will generate H2CO3, carbonic acid, and carbonic acid will be dissociated into H plus and bicarbonate. So because of that, you will get acid load. Okay. And in contrast, if there is hyperventilation, because CO2 will be washed off, and because CO2 is acidic, acid will be washed off of the body and you will get respiratory alkalosis. Then talking about metabolic acidosis, because of excessive H plus, you will get a metabolic acidosis and the pH will go down. And on the other hand, if the H plus goes down, you will get metabolic alkalosis. So in addition to these main disorders, you can get mixed disorders. Sometimes you can get a respiratory acidosis and a metabolic acidosis, or respiratory acidosis and a metabolic alkalosis, or you can get any combination. Okay. Suppose there is a COPD patient. So in COPD, the patient won't be able to clear off the carbon dioxide optimally, isn't it? Because of the problems in the airways, so there will be carbon dioxide accumulation, and because of that, to compensate in the long term, there will be a metabolic alkalosis. You get a metabolic alkalosis because there will be bicarb retention. Okay. So if you do a blood gas in a COPD patient, you might get a pH of 7.31 with a CO2 of 50, which is not normal. But as the kidneys are compensating, there will be retention of bicarb, and bicarb might be even 40 in that patient. Okay, but the patient will be eating and drinking and walking and doing his day-to-day activities in normal way. Okay, so in that case, you can see a mix. Sorry. So if this COPD patient comes, say with a chronic exacerbation of COPD, then because of that there will be accumulation of CO2, and if you do blood gas, so the CO2, if the baseline CO2 is 50, the in an exacerbation CO2 will be 60, but the bicarb would be 40. So you can see the combined picture in that patient, the metabolic alkalosis and respiratory acidosis. So that's one example, but we'll come to examples when we do the cases. Do you have any questions regarding that? Regarding the buffering and the main 4 disorders, respiratory acidosis, alkalosis, and metabolic acidosis and alkalosis. Before we move on to the next part, if you have any questions, please ask. ඕනකක්කා සිංහලෙන් හරි ඉංග්‍රීසියෙන් හරි. ප්‍රශ්නකුත් තියෙනවද? ලැජ්ජ නැතුව අහන්නනේ මේ. නැද්ද? හරිනේ ඊළඟට යන්න. So next one is to interpret ABG. Okay, when you talk about ABG, what are the things that you can see in a blood gas report? Lahiru.
Sir?
Blood gas report එකේ මොනවද තියෙන්නේ? What are the
Bicarbonate concentration and
මුලින්ම තියෙන්නේ මොකද්ද?
pH.
patient ගේ නම ගම විස්තර PhD ඒවත් තියෙනවනේ ඒවා අමතක කරන්න. So ඒවත් බලන්න මේ patient ගේ ඒක තමයි blood gas එකක් ගත්තම බලන්න ඕනේ මේ patient ගේද කියලා මුලින්ම. හරිනේ? So you must check whether the patient, the blood gas belongs to that patient. Okay, so what are the things that you can see? One thing is pH. What else?
And partial pressure for oxygen, carbon dioxide, and bicarbonate, lactate, and electrolytes.
What are the electrolytes you can see?
Sodium, potassium, calcium.
Okay. What else?
Fluoride.
Okay, what else? Okay. So when you take an ABG, you must check whether it's the patient's ABG. නැත්නම් වෙන කෙනෙක්ගේ ABG interpret කරලා හරියන්නේ නැහැ. So check the name, age, and name, age, and in the hospital patients, what you should look is specifically at the BHC number. And check when was it done. Then other patient දිහා බලනවා නම් පෙරේද ගහ blood gas එක interpret කළාද නැහැ. So check the time and date of the check the time and date the blood gas was done. So it is applicable to any investigation, the chest X-ray, ECG, full blood count, for anything. You check all these things before interpreting it. Okay. So as Lahiru told, the components of the ABG are, you get the pH, then partial pressure of oxygen. When you check the partial pressure of oxygen, always check what should you check?
Whether it's an arterial sample or a venous sample.
Okay, that's one thing. What else should you check? Say it's an arterial sample, උඩින් ගහලා තියෙන arterial කියලා. the inspired concentration of oxygen, isn't it? Then ABG at PO2 100. එතකොට බලන්න ඕනේ මේ කොච්චරද කියලා FiO2 එක, the inspired concentration of oxygen. So if the PO2 is 100 with 21%, it's okay, isn't it? If the PO2 is 100 with 100% oxygen, it's not okay. So always check the inspired concentration of oxygen, or FiO2 කියලා ගහලා තියෙන්නේ. FiO2. You must always check the inspired concentration of oxygen when you look at the partial pressure of oxygen. Okay. Then you check the partial pressure of carbon dioxide. You can see the things you can see. Then you get the bicarb concentration. And there's something called base excess. BE capital BE. I'll tell about it, don't worry. Then you get the lactate concentration. Then as like told the electrolytes, you get sodium, potassium. Normally you get sodium, potassium and chloride, but in special occasions you can get calcium and magnesium as well. Then in addition, you can get the hemoglobin concentration and the packed cell volume as well. Okay. So basically those are the things that you can see in the blood gas. Okay. So talking about each and every component, the pH is, the normal is 7.35 to 7.45. If there's acidosis, the pH will be less than 7.35, and if there's alkalosis, the pH will be more than 7.45. Okay. Then regarding the oxygen concentration, then for normal it's around in a normal healthy patients. In a young patient, the partial pressure of oxygen will be between 90 and 100. Okay. But in an elderly patient, say if you do a blood gas in an 80-year-old patient, an arterial blood gas, sometimes it will be maybe 80, which might be normal to him. So there's an equation to calculate the normal partial pressure of oxygen for people, but at your level you don't have to know it. Just remember that normally the partial pressure of oxygen at room air would be around 90 to 100. Okay. Then when you do the carbon dioxide, partial pressure of carbon dioxide, it will be between 35 to 45, or maybe 35 to 40. Okay. So if there is if it's less than if the partial pressure of carbon dioxide is less than 35, it will lead to respiratory alkalosis, and if it's more than 45, it will lead to respiratory acidosis. Okay. Then you get the bicarb concentration, which is between 22 to 26. Usually, roughly, it's around 24 milliequivalents per liter. Then you get this concept thing called base excess. Does anybody know what's the meaning of base excess? When you do a blood gas, you see this base excess. Sometimes you get positive values, sometimes you get negative values. What's the meaning of base excess? Anybody? Base excess කියන්නේ මොකක්ද දන්නවද?
So it is the amount of base that needs added to remove from sample in which normal pH and normal carbon dioxide level.
Okay, fine. So base excess, as the name implies, it's the additional amount of base excess. Base excess, the additional amount of base which should be added to blood to bring the pH back to normal. ඒක තමයි base excess කියන්නේ. කොච්චර base ප්‍රමාණයක් දාන්න ඕනද කියලා blood වලට pH එක normal ගේන්න. දැන් base excess minus 10ක් කියන්නේ you should add 10 of base to bring the pH back to normal. Base excess plus say base excess is plus 10. That means that there is excessive base. That means if you want to bring the pH back to normal, you should remove 10 of base. හරිනේ? Base excess කියන්නේ කොච්චර base ප්‍රමාණයක්? ඒක ඇත්තටම මේ misnomer එකක්. දැන් base acid එක්කෙනෙක්ගේ base excess එකක් නැහැ නේ. ඒක minus වලින් දාන්නේ. acid එක්කෙනෙක්ගේ තියෙන්නේ base deficit එකක් නේ. base වල අඩුවන්නේ තියෙන්නේ. ඒක තමයි -10 කියලා තියෙන්නේ. -10 base deficit එකක් තියෙන එක නිසා patient acidosis. ඒක නිසා you need to add 10 of base to bring the pH back to normal. If there's a base excess of plus 10, That means we have to remove 10 of base to bring the pH back to normal. ඒක තේරුණාද base excess කියන එක? අන් තේරුම් නැත්නම් අහන්න දැන් නැත්නම් මම දන්නෙත් නෑ මේ නිකන් කියනවා. Did everybody understand the concept of base excess? That means the amount of base which is needed to bring the pH back to normal. If it's minus, it means that you have to add base to bring the pH back to normal, which is seen in acidosis. But if it's positive, it means that there's excessive base, which means that you have to remove base to bring the pH back to normal. Any questions about it? Okay, so the next part. So there is something called standard base excess. Now in the blood, we have the acids, and in addition, we have the acids in the form of byproducts which is produced during metabolism. So one of the acids is carbon dioxide, which is controlled by the respiratory system. So when we do the blood gas interpretation, we take the respiratory system and the renal system, which excretes the acids produced in the body, as two components. And we, for convenience, we interpret as two components, like the metabolic component and the respiratory component. So when we interpret the base excess, it belongs to the metabolic component. Okay, so if we don't forget about the respiratory component, when we interpret the metabolic component, there will be interference. So because of that, people have formulated a thing called the standard base excess. So when you do the standard base excess, you remove the metabolic component. So to remove the metabolic component, you can't just forget about the respiratory system. For that, what you do is you make it a standard value. Like you make the partial pressure of carbon dioxide, which is controlled by the respiratory system, at 40 millimeters mercury. By that, you forget about the respiratory component when you interpret the metabolic component. That means you standardize the respiratory component. So in addition, you have the hemoglobin, which acts as a buffer in the body. So in various people, the hemoglobin concentration would be different. Because of that reason, you standardize the hemoglobin concentration as well. So you make the concentration of hemoglobin 5. So standard base excess is the amount of base which should be added to the body or removed from the body at a carbon dioxide of 40 and a hemoglobin of 5 grams per deciliter to bring the pH back to normal. Okay. Basically, if you tell in simple terms, when you analyze the metabolic component, you use this concept called standard base excess by standardizing the partial pressure of carbon dioxide to 40 and hemoglobin concentration to 5 grams per deciliter. Any questions about that? Did you understand the difference between standard base excess and base excess?
Yes, sir.
කාටත් තේරුණාද? මම තේරුම් නැත්නම් කියන්න ඒක. පාරමි, did you understand?
Yes.
Is there anybody who didn't understand the difference between base excess and standard base excess? Base excess කියන්නේ it can be measured at any partial pressure of carbon dioxide and any hemoglobin. But if you do the standard base excess, you do at a carbon dioxide concentration of 40 and a hemoglobin concentration of 5 grams per deciliter. So by doing that, you forget about the respiratory system. Alright? Okay, so we talk about the pH, the oxygen, the carbon dioxide, the bicarb, and the base excess. Then we have the lactate. The lactate level is usually normal is less than 2. And you have then the electrolytes, sodium, potassium, calcium, magnesium, and bicarb. Okay. Then comes the question how to interpret the ABG. Okay. So can you see the screen?
Yes, sir.
Screen එක පේනවද?
Yes, sir.
Okay, when you interpret the ABG, okay, fine. So when you interpret an ABG, there is a simple method which is which we teach in the ALS courses. So it's a 5-step process. So when we use that, first we check how is the patient. That's the first question we should ask. Then we assess the oxygenation. Then we determine the pH, which is the hydrogen ion concentration. Then we check the respiratory component. Then we check the metabolic component. Okay, so these are the 5 steps that we do when we do the ABG. So how is the patient is very important. Say somebody gives you a ABG and asks to interpret it without knowing the history of the patient. It's difficult to interpret the ABG. Sometimes you can interpret the numbers which is there, but it won't add any value without knowing the history of the patient. So first thing is you must see how is the patient. Like if you go to the ICU, if you see the ABG, first thing you must examine the patient and look through the history and see how the patient presented and how the patient progressed during the ICU stay and what is his current status. So those are the things that you should ask. And regarding past medical history, past surgical history, those things you should have a complete idea about the patient before interpreting the ABG. Okay, then second step is assessing the oxygenation of the patient. So oxygenation is assessed by looking at the partial pressure of oxygen. So it's usually shown in millimeters mercury. And as I told, when you interpret the partial pressure of oxygen, you must always look at the inspired concentration of oxygen or FiO2. It can range from 21% to 100%. Okay, so without knowing the partial pressure of without knowing the inspired concentration of oxygen, you can't evaluate the oxygenation. It's useless. As I told, somebody can have a partial pressure of oxygen of 100 with a FiO2 of 21 as well as with 100. So both the 100 one is pretty sick with the bad oxygenation, and the one with 21% FiO2, the oxygenation is quite good, isn't it? So there is a simple way to calculate the expected partial pressure of oxygen in the blood when you know the FiO2. Say in a patient who is having a FiO2 of 21%, say FiO2 is 50%, then we should have an idea about the oxygenation, isn't it? Otherwise we can't interpret it. The 50% තියෙන කෙනාගේ PO2 එක roughly blood වල කීයක් තියෙනවද කියලා දැනගත්තොත් අපිට පුළුවන් oxygenation good the bad ද කියන්න නේ. So this formula is if the FiO2 is 50, then the expected partial pressure of oxygen in the blood is 40, but the unit should be in kilopascals. If the inspired concentration of oxygen is 50% and you take it in kilopascals, the expected partial pressure of oxygen in the blood should be 40%, always less than that. Inspired concentration is 60% now, expected concentration in the blood balloon be 50%, 50 kilopascals. So kilopascals කියන එක millimeters mercury කරන්න you should multiply by 7.5. හරිනේ? Then 10 kilopascals කියන්නේ millimeters mercury 75. 50 kilopascals කියන්නේ 7.5 වැඩි කරාම 300 ගානක් එන්නේ නේ. 40 kilopascals කියන්නේ when you multiply by 7.5 it's 300 millimeters mercury. So suppose there's a patient with FiO2 of inspired oxygen concentration of 50%, then we expect partial pressure of oxygen in the blood of 40 kilopascals. And because we are dealing with millimeters mercury, to get into millimeters mercury, we have to multiply it by 7.5. So we get 300. Then if I were to get 20 now, 20 kilopascals FiO2 නම් එතකොට expected oxygen concentration එකන්නේ 10 kilopascals නේ blood වල. ඒක 7.5 වැඩි කරාම 75 වෙන්නේ. That's a rough estimation, not a very accurate one. So if you look at the blood gas, if you want to see whether the oxygenation is adequate or not, you can use this simple rule. Did you understand inspired oxygen concentration and the expected partial pressure of oxygen in blood?
Yes, sir.
Sir, I have a question.
Yeah.
FiO2 is 20%. We already in normal person also inspired 20% oxygen. So
Yes.
how it comes 75 millimeter of mercury?
That's a rough estimate. Like හරියට මැකියුරට නැහැ. ඉතින් අර නිකන් rough හිතන ගන්න දැන් 70 normal එකෙනෙක් ගත්තම නිකන් 90 තියෙන්න ඕනේ.
Okay, sir.
21 එක මේ attribute කරන්න එපා ඒකට. නිකන් දැන් 50% ඒක rough එකක් නේ අපිට roughly දැනගන්න. දැන් මේ 75% දැන් 21% ඉන්න කෙනා 75 නේ එන්නේ. ඒතර ලොකු දැන් සාමාන්‍යයෙන් ගත්තම 90 100ක් තියෙනවා. 25ක gap එකක් එනවා. ඒක එච්චර හිතන්න එපා මේ. ඔය ගොඩක් කලාවට ගන්න ලොකු oxygen concentration එකක් තියෙන කට්ටිය. කියන්නේ 50 ඉන්නවනම් අපි ටක් ගාලා බලා ගන්න ඕන නම් දැන් 50 වලින් 10ක් කරගෙන 40 හතෙන් පඩි ගන්න 300ක්. එහෙම. ඒක අර 21% එකක එච්චර ගණන් ගන්න එපා. මේක rough estimate එක විතරයි.
Okay, sir. Thank you.
Anything you want to ask? Okay. So the next step is you determine the pH, the hydrogen ion concentration. So the normal is 7.35 to 7.45. If it's more than 7.45, it's alkalosis, and if it's more than less than 7.35, it's acidosis. Alright. Then you determine the respiratory component. So respiratory component is showed by the partial pressure of carbon dioxide. Usually it's between 35 to 45. If it's more than 45, it's respiratory acidosis, and if it's less than 35, it's respiratory alkalosis. Okay. Then you determine the metabolic component. If the pH is less than 7.35 and if the bicarb is less than 22, it means that the patient is having metabolic acidosis. And if the pH is 7.45 and bicarbonate is more than 26, it means the patient is having a metabolic alkalosis. So if you look at this one, pH 7.35, bicarbonate 22, it means that the base excess is -2. So base excess, the normal value is from -2 to +2. That means in a normal patient, in some patients, you might have a base excess of -2. That means you need to add 2 of base to bring the pH back to normal. And in some patients, you might have excess of base. That means you have to remove 2 of base to bring the pH back to normal. Okay. So ideally, the word should be base deficit and base excess, isn't it? If it's -2, it should be base deficit because there's a deficit of base. And if it's plus, ideally it should be base excess, isn't it? Because there's excess of base. But for the I don't know why they have done this like that. For base excess, if it's acidosis, you denote by minus, and if it's alkalosis, you denote it by positive. Alright. So going back to the 5-step approach again. First, you see how is the patient. Then you assess the oxygenation by looking at the partial pressure of oxygen or PO2, which should be roughly around 90 to 100. Then you determine the pH, see whether it's acidosis or alkalosis. Then determine the respiratory component, see the CO2. If CO2 is less than 35, it's respiratory alkalosis. And if it's more than 45, it's respiratory acidosis. But then you look at the metabolic component. If the bicarb is 22, it's less than 22 with a pH of less than 7.35, it's metabolic acidosis. And if the pH is more than 7.45 with a bicarb of more than 26, it's metabolic alkalosis. Okay. Any questions up to that? We are going to discuss some questions. What we'll do is we'll do two questions and we'll stop it there. Otherwise, it will be too much for you all. So, because most of the people are told that we'll do 2 questions and we'll stop it there. So this is a very simple method to determine to interpret the blood gas. So there are various advanced methods. You don't have to know those things. You can learn those when you come to do postgraduate studies. But for at your level, if you know these 5 steps, how to evaluate blood gas using these steps, it's adequate. Okay. Anything you want to ask? Okay, first question. So this is the first question. First question is, you're called to the EDS emergency department to see a 21-year-old woman who was thrown from her horse at a local event. On the way to hospital, she has become increasingly drowsy. After receiving a SBA handover, you perform a rapid ABCD assessment and find SBA is situation, background, assessment, and recommendation, which is a convenient way to do a handover. Okay, situation, background, assessment, and recommendation. Situation is this is about a lady who was thrown from the house. Background is we don't know the background. She might be looks as if she is normal health, isn't it? Because she's a 21-year-old. Recommendation is what you recommend the handing over team to do, maybe to intubate and ventilate or to do a CT or something like that. So regarding the ABCD assessment, oh no, this question. I'll answer your question. Don't worry. So regarding the ABCD assessment, the airway is clear. The patient is tolerating an oropharyngeal airway and she's on 85% oxygen. Breathing wise, the patient is hypoventilating. Respiratory is 8 and saturation is 99. And there's reduced equal air entry both lungs, percussion or present on both sides, and trachea is central. Pulse rate is 54. Blood pressure is 160 by 6 by 105. And she's opening eyes to the pain, and there are incomprehensible sounds and localizing to pain with a GCS of 9. And exposure, there's IV cannula in the right forearm and there's no external bleeding. So you have taken a blood gas and the acid-base status. Okay, so Lakshita, when you if you go through the history of this assessment, what are your concerns about this patient?
Hello.
Yeah, I can hear. So if you get this handover and if you examine this patient and if you see these details, what are your concerns regarding this patient?
The patient is clinically unwell.
Okay.
She has a low GCS and have a very low respiratory rate. And blood pressure is high. Mm, no visible external bleeding is there. The patient is unwell and need immediate attention.
Okay, fine. Somebody else, Timasha. Timasha innavada? Okay, Y9 guest. මොකක්ද කියන්නේ? වික්‍රමනායක. උද්‍යන්න වනිකරත්න. වෙනුර කියන්නකෝ. කවුරුක කියන්නේ වෙනුර. If you see this patient and if you get this handover, what are your concerns?
So this is a 21-year-old woman, so she probably has no other comorbidities. He was thrown from a horse, so there may be some head or neck injuries or any other trauma. She has become increasingly drowsy, which means that head injury is possible. Her airway is all right, clear, tolerating. She's bradypneic and air entry is reduced, so there may be some lung pathology. And her pulse rate is mildly bradycardic, but regular, and pulse blood pressure is all right. But her GCS is 9, very close to 8. And she's otherwise okay. So due to her impaired GCS, her ventilation would be affected.
Okay, fine, good. Okay. So as you told, this is 21-year-old and she is unlikely to have any comorbidities, but there's a possibility, like if a young patient comes, it's possible that the patient can have asthma or maybe epilepsy, or even the patient can have diabetic ketoacidosis. Type 1 diabetes, isn't it? The insulin-dependent diabetes. But always you can take the history and assess for the comorbidities. So unless if a history is available, you can make a fair assumption that the patient is otherwise healthy. Okay. Then looking at when you get this is a trauma situation, isn't it? As I told last week, when you get a trauma patient, you must look at the mechanism of injury. Like the patient has been thrown from a horse at a local event. That means there should be a significant injury, isn't it? It depends whether the house was running or the patient was stationary. If you are thrown out from a running horse, you can get a significant injury. On the contrast, if you get an injury from a horse who is stationary, you will get mild injury. And it says the patient is drowsy and patient is becoming increasingly drowsy. So that means if the patient is drowsy, that there's something going in the head, isn't it? So we can jolly well make a fair assumption that the patient is having head injury. Then you do the ABCD assessment and it shows that the patient is on 85% oxygen, which is close to 100%. That means the patient is needing a lot of oxygen to maintain the saturation at normal level. So with 85% oxygen, she is saturating 99%. That means she must have had low saturations with lower inspired concentration of oxygen, and then the patient's respiratory rate is 8, which is not normal, which is like on the low side. So that's also a clue which is showing that the patient must have had the head injury. Okay. Then if you look at the pulse rate, the patient is bradycardic and hypertensive. Bradycardia is if the patient's pulse rate is usually if the less than 60. And for a 21-year-old, the blood pressure is 160 by 105. So it can be multifactorial. One thing is it can be due to even due to pain or anxiety. Or then if the patient is bradycardic and hypertensive, does this ring alarm bells in your head? Bradycardia in hypertension is something that you can get in head injury, isn't it? Something called Cushing's reflex. අහලා තියෙනවද ඒක? Cushing's reflex කියලා එකක් තියෙන්නේ. Head injury patient එක බලන්න පුළුවන් if the patient is bradycardic and hypertensive. It's a concern. And then if you look at the GCS, it's 9, isn't it? Which shows that according to the GCS classification, the patient is having moderate head injury. And in exposure, there's nothing significant. There's no bleeding. So if you do a blood gas in this patient, what are the things that you might expect to see in this patient in the blood gas report? Like without looking at the blood gas, we'll formulate blood gas and see whether it's tallying with our one. How to බලන්න. මේ blood gas එක ගහුවොත් මේ values ටිකක් දාන්න බලන්න pH එකටයි PO2 එකටයි PCO2 එකටයි bicarb එකටයි base excess එකටයි lactate එකටයි. ජීවන්ත.
There may be respiratory acidosis.
දාන්න මේ values ටික දාලා කියන්න pH මෙච්චරයි PCO2 මෙච්චරයි PO2 මෙච්චරයි කියලා එහෙම කියන්න. pH එක
pH
7.25 මම දාන්න එක. හරි. pH is 7.25 then PCO2
60.
Okay, 60. PO2
100, 150.
Okay, why did you put 100, 150? Now she's on 85% oxygen.
But on 85, she's achieving 99%.
Okay, fine.
So there should maybe a poor oxygenation.
Okay, fine. Then bicarb.
Slightly low, 22, 21, 20.
Why? So if there's respiratory acidosis, there isn't time to compensate by the kidneys, isn't it? Ideally, the bicarb should be go up if the patient is high respiratory acidosis, ne? Harine? But it takes time like 48 to 72 hours for the kidneys to compensate if there's a respiratory problem. So why do you put a bicarb of 22 in this patient?
No time to compensate.
Oh, okay. No, there's no time to compensate. Why is it not 24? Why 22? 22 chuktak kaduine.
Okay, then 24.
No, but with the injury, there can be a bit of acidosis, isn't it? Like there can be, we don't know the other injuries. Maybe if they say if it's a pure head injury, because of the injury itself, because of the trauma itself, there can be a slight metabolic component as well, but you can forget about it. Okay, base excess.
Minus 10.
Or minus 2, minus 2 or minus 3. There can be slight metabolic acidosis or it can be normal. Base excess and minus 2 in the plus 2 වෙන ගන්න. හරිනේ? Then lactate.
Lactate high.
Why?
Because due to injuries.
Same patient doesn't have other injuries. Only head injury. Then lactate can be normal, ne? Lactate. If there's a head injury.
If there is no other injuries, then it should be normal.
But if the oxygenation is poor due to the head injury, then lactate should be high, isn't it?
But he's maintaining adequate blood pressure and saturation right now.
Yeah, the lactate can be normal or it can be high. We can't really tell about it. Although he's maintained a saturation of 99, though as you told, the oxygenation might be poor, isn't it? So the lactate can be high. We really don't know.
Okay.
Arane? Does it make sense?
Yes, sir.
Did you all understand? So in this patient, we made a hypothetical blood gas with a pH of 7.25 with a CO2 of 60 because the respiratory is 8, and we thought that the patient is having some head injury. Because of that, the patient might be hypoventilating and retaining carbon dioxide. Then regarding oxygenation, we had a value of 150. If the patient is on 85 oxygen, that means inspired concentration of oxygen is 85. That means if you take the expected partial pressure, it will be 85 minus 10. That means 75 kilopascal. And if you multiply by 75 into 7.5, how much will it be? Something in the 400s, isn't it? So ideally, the patient should have a partial pressure of oxygen more than 400, but he's having around 150. The value which we put, but it's low. And bicarb is 22, that's slightly reduced, and base excess is -2, and lactate is 2. That's the hypothetical one. So let's see what the real one is. So this is the real blood gas which is shown. PO2 of 18. So if you multiply, I'll tell you the exact millimeters mercury value. The value in millimeters mercury is 142. So the PO2 is 142 with 85% oxygen. pH is 7.26. PCO2 is 8.2. That means if you multiply it by 7.5, it's around 56. Say PCO2 is 56, bicarb is 26, and base excess is minus 2.5. Okay, so can somebody interpret this gas? Lakmali. Lakmali, can you interpret this gas? Chaturika.
pH is less than 7.35. It is acidosis.
So what's you use the 5-step approach. So what's the first question that you should ask? First question, how is the patient? Harine?
How is patient question?
Okay, first question is how is the patient? So how is the patient?
How is patient condition?
Okay.
Then as a oxygenation.
Okay, what can you tell about the oxygenation?
Partial show of oxygen is
150. Say 18 is 100.
More than normal value. Then pH level is less than the normal range. It means acidosis.
Okay.
Partial pressure of carbon dioxide more than the normal range. It means respiratory acidosis.
Okay.
So bicarbonate level within the normal range. So patients in the uncompensated.
Okay.
So this is a respiratory acidosis with uncompensated.
Okay, this is an uncompensated respiratory acidosis. That's correct. So acute respiratory acidosis, isn't it? But the problem is you told that the oxygenation is normal. Why did you say that? You just look at the values, isn't it? You told that since the PaO2 is 18, which is the normal is more than 10, you told that it's normal. But as I told, when you interpret the PaO2, you must always look at the FiO2, the inspired concentration of oxygen. So in this patient, the inspired concentration of oxygen is 85%. So that means the patient is on lot of oxygen. In spite of being on lot of oxygen, the patient is having a PaO2 of 18. Like if the patient is, if the PaO2, if the FiO2 or the inspired oxygen concentration is 85, the expected PaO2 is what? I told that you must, it will be less than 10 of the inspired one, right? If it's 85%, the expected partial pressure of oxygen is 75% kilopascal, 75 kilopascals. If you multiply it by 7.5, it's close to 500, isn't it? Although the expected one is 500, something 500 odd, patient is having only 18 or 150. So that means the oxygenation is not that good. So the answer is the patient is having poor oxygenation, and she's having a acute respiratory acidosis or uncompensated respiratory acidosis. That should be the answer. Okay. Did you understand that, Lakmali? Did you understand? Okay, fine. So there's a good question. Nobody asked it. I was going to explain it. Somebody has asked, so if the patient maintains saturation at 99%, why we need to worry about oxygenation? I mean, why we need to consider about PaO2? Can somebody answer that question? Okay, so can you explain the oxygenation part? Somebody has asked that question. Why aren't we worried about oxygenation? Why, if the saturation is 99, why are we worried about oxygenation?
So because if we drop the 85% concentration to normal 21%, then the patient is not going to survive because his respiration, because his respiratory system is not working properly.
Okay, that's okay. So when you consider oxygen hemoglobin dissociation curve, matagada? Rupiat put in the I'll have to Google a Rupe and Google a picture and tell you, otherwise you will not understand. Can you see the curve? Can you see this?
Yes.
So when you look at the oxygen hemoglobin dissociation curve, there's a flat upper part, this one, and there's a sigmoid shape part and a flat lower part. Okay. So when you look at the flat top part, so when you look at this part, so when the such may rupechana harine podi venekadana. Okay, can you see this one?
Yes, sir.
Okay, so when you look at the oxygen hemoglobin dissociation curve, there's a flat upper part and there's a sigmoid part, and there's a bit of flat lower part. So the thing is the saturation of hemoglobin. So the x-axis is the partial pressure of oxygen, which is millimeters mercury, and the y-axis is the saturation of hemoglobin. So if you look at the saturation, there's the saturation. If you look at this part, the saturation is 95. When you look at the upper part, which means saturation is 100. The saturation is of 100 can be if the patient is having saturation of 100, he can have a range of PO2s. The partial pressure of oxygen can range from maybe normal, which is 90. Make pennala naha. Me hari 90 විතර. 90 වලට මේ කෙලින් වෙන ගන්න. 90 දැන් දිගටම වෙනකන් partial pressure of oxygen oxygen saturation එක තියෙන්නේ 100, but excess එක දිගේ ඕන ගානක් තියෙන්න පුළුවන්. දැන් partial pressure of oxygen එක 90 වුණා saturation තියෙන්නේ 100. partial pressure of oxygen එක 120 වුණා saturation තියෙන්නේ 100. partial pressure එක මෙතන මේ පැත්තේ තිබුණා 500ට ගියත් saturation තියෙන්නේ 100. එතකොට ඒකෙන් අපිට පෙන්වන්නේ it shows that the saturation is not a very good indicator of how the blood is being oxygenated, because at a PaO2 of 500, maybe 400, maybe 300, maybe 200, or even 90, the saturation will be 100. So say if the patient is on 100% oxygen, the saturation will be 100, because 100 already have a PO2 again saturation එක 100 වලදී මේ හරියන්න පුළුවන්. ඒ කියන්නේ PO2 එක 500ක් වෙන්න පුළුවන්, 400ක් වෙන්න පුළුවන්, 300ක් වෙන්න පුළුවන්, 200ක් වෙන්න පුළුවන්, 90ක් වෙන්න පුළුවන්. නමුත් saturation එක තියෙන්නේ 100. So that's why in patients we need to do a assessment of the real PaO2 without going by the saturation, because saturation might be a misnomer. හරිනේ? So because of that, if the patient is maintaining a saturation of 99 with 85% oxygen, it doesn't mean anything. One thing is, if the patient is having a saturation of 89% with 85% oxygen, we should know how he was before, like before going on to 85%, how his oxygen requirements went up. A single value usually doesn't mean anything. But because we have done a blood gas, as I showed earlier, so we have done a blood gas and we have got a value of 18. That means, which shows 18 can roughly around 150, but he's on 85% oxygen. 85 in order, usually but he's having 18. That shows that the patient is having poor oxygenation. So did you all answer that? Did you all understand that? How saturation can be misleading and why you need to measure the partial pressure of oxygen in the blood?
Yes, sir.
In complete diagnosis, is it necessary to mention about the poor oxygenation as well? Oh, yes. When you interpret a blood gas, you have to always comment about the oxygenation. Otherwise, it's inadequate. So you can use the simple rule to assess it. Then there's another question. So bicarbonate level is higher than normal. Cannot it be due to partial compensation? Bicarbonate level in this blood gas, according to this calibration, normal value is between 22 to 26. So we have to consider it as normal. And the other thing is there isn't time for the renal compensation to occur if there's a respiratory acidosis within a given short period time, because this is like within a very short period, isn't it? So within like 2 to 3 hours, the renal mechanisms not will come into play because there's an adequate time. So there is no time for compensation. either partial or total. Any other questions? You can ask anything. We'll discuss one more case and we'll do the rest next week. Any other thing? ඕනයක් අහන්න. So there's another question. What about Winter's formula to identify acidosis or alkalosis? So then when there's compensation, say if there's a metabolic respiratory acidosis, I told that the kidneys should compensate, isn't it? And if there's a metabolic acidosis, because of the problem in the kidneys, the respiratory system should compensate. So during compensation, we can assess using a formula whether the compensation is adequate. For example, if there's a metabolic acidosis, if there's compensation, the CO2 should be low, isn't it? So CO2 should be washed off, and it should try to bring the pH to a near normal value. And there's a formula to assess how low the PCO2 should be. That's called the Winter's formula. By using the Winter's formula, we can get a rough idea about the rough CO2, which should be after the compensation happens. So at your level, you don't have to know about the Winter's formula. If you want, you give a call to me. I'll explain it. මේ ප්‍රශ්න අහපු එක්කෙනා ඕන්ලයින් කියලා දෙන්න කෝල් එකක් දෙන්න මේ ටයිප් කරලා මෙසේජ් වලින් කියලා දෙන්න අමාරුයිනේ ඔයාට ඕන්ලයින් කෝල් එකක් දෙන්න කියලා දෙන්න ඒක මෙතනට වැඩි ඇත්තටම if you are interested you can call I can answer 077 263 කෝල් එකක් දෙන්න කියලා දෙන්න. So then there's another question. Can you please tell us about renal compensation a bit? So renal compensation happens when there is a respiratory acidosis. So what renal compensation? What you mean by renal compensation is the kidneys try to get rid of the excessive acid. So normally in normal people, the kidneys will excrete the acids producing metabolism. Otherwise, there will be a buildup of acids. For example, say there's a patient with acute renal failure or acute kidney injury. And because the patient is not passing adequate amounts of urine, the patient will be accumulating acids. And the patient will have acidosis. Okay. Then the what renal compensation does is it tries to, one thing is it secretes H+ actively from the tubules and get rid of the acid. Other thing is it absorbs bicarbonate actively and tries to maintain the adequate bicarb concentration without disturbing the acid-base balance. And there are certain mechanisms how the renal kidneys buffers H+. It can secrete ammonium and phosphate. You can read up in the physiology books. But we will not go into finer details about physiology. Just remember that the kidneys can secrete H+ and combine it with buffers such as ammonia and phosphate and excrete the H+, or else the kidneys can absorb bicarbonate and maintain the acid-base balance. Alright. The next question is 85%. මොකද්ද කියලා දැනගන්නේ කොහොමද? මේ දීලා තියෙන breathing 85% oxygen කියලා. So the patient might be on a venturi or he might be getting so there might be something to monitor the oxygen inspired oxygen concentration. 85% කියලා දැනගන්නේ කොහොමද කියන එක වැදගත් නෑ. ඒකෙච්චර අමතක කළා දාන්න. Then there's a question, sir, what is the problem if patient can maintain saturation even with low oxygenation? Anyway, he's maintaining this. As I told, saturation, if there is a problem, even if the patient is maintaining saturation even with low oxygenation. So in head injury patients, sir, what is the problem if patient can maintain saturation even with low oxygenation? So in head injury patients, as I told you, when we discuss about head injury, It means that in a head injury patient, we need at least a partial pressure of 100 of oxygen in the blood. Okay. So this patient with 85%, the patient is having a concentration of 150. But with 85%, the ideally the patient should have a concentration of 500. So that means there should be a problem in oxygenation. But in this patient, the adequate target of oxygenation is maintained. So reached, sorry, not maintained, reached. It's 150, although the patient is needing 100. But in the context of head injury, if the patient is having a problem in oxygenation, it means that there should be some problem. Like for instance, and in this case, when you consider the other bit of history as well, such as the low respiratory rate, we can think that the patient is having a problem in the respiratory system, which needs intervention. Okay, that's why we need to worry about the oxygenation and intubate this patient, like the patient, taking the patient as a whole. Other thing is, we can't leave the patient on a high degree of oxygen for a long time. We can leave the patient on 60% oxygen if the patient is on 60% oxygen or less, we can keep it for a duration we like. But if the patient's oxygen concentration is more than 60%, there's a problem of oxygen toxicity as well. So we have to come down on the oxygen concentration as soon as possible while maintaining the adequate levels. That's why we are worried about saturation. So that's why we need to. The next question is, sir, what is the importance of knowing PaO2? So I have explained it. Bicarb one is also, so in here bicarb is in the upper margin. Is it due to the carbon dioxide dissolving in blood initially? It can be. The next question, in acute settings of H plus concentration is increased, so initial bicarbonate doesn't neutralize it or not? It neutralizes. Vijit, I'll give a call to you, or we can have a discussion about this. Please text your number to 77200303. I'll give a call to you. Any questions you want to ask? Shall we stop it there, because now it's almost 2 hours. We'll do the questions next day. Is there anything that you want to ask? Any other questions? So I quickly summarize what we did today. So initially we did we explained how we could do a blood gas, the indications, the contraindications, and the complications, and the procedure itself, like taking consent from taking the blood gas to the ICU. Then we discuss about the anatomy of a blood gas, starting from pH, PCO2, PO2, then bicarb, base excess, lactate, then electrolytes. Then we discuss the 5-step approach to discuss the ABG, starting from how is the oxygenation, then how is the patient, how is the oxygenation, the carbon dioxide, then the metabolic component. Then we discuss about the case, about this head injury patient who is having a high CO2. Anything you want to ask out of the things we learned today? Any questions? අහන්නවද මොකද නැත්නම් නවත්තමු අදට නැත්නම් වැඩි මේක කාටවත් තේරුණාද ඔක්සිජනේෂන් එක සැචුරේෂන් එක වෙනස?
Yes sir.
you must. One thing is you can use the hemoglobin oxygenation dissociation curve, or as saturation 100 you must appreciate that there is a wide range of PO2 which you can get with a saturation of 100. So saturation 100 is not a good thing in critical ill patients because it can be misleading. And always you have to consider the inspired concentration of oxygen when you interpret the PaO2 value. That's the other important thing. Okay, we stop it there. Then if you want, we can do a class before next Wednesday, so we can finish these questions and then we'll discuss another topic on Wednesday. Let's see. Okay, then we'll stop it there.
Okay, sir. Thank you.
Okay, bye bye.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.